Good evening, students. So, your NEET MDS is finally done, and good evening, students. How are you all? The NEET MDS 2024 is finally done, right? So, today we are here to discuss the recalled questions of oral and maxillofacial surgery. So, first of all, the questions that I went through, I was extremely relieved to see that few of the questions were discussed or reinforced in our predictor series. Apart from that, many of the questions or many of the visuals or one or two history based questions I have discussed in my previous sessions or in my classes as well. So now when you have, say, 10 to 12 questions from a particular subject, there is naturally bound to be some 2 or 3 questions that will catch you off the track, or you might not have an idea of. I have said this previously also, and I've said this before also, that there always will be questions that might create a confusion or that you might not have heard of. Now, most of the questions, if you've also gone through my predictor series, 3-4 questions were directly, I had either asked you to revise the topic before going to the exam, or I had given you a similar scenario, or I had given you a similar question, or I had revised those points before we went for the exam. So more or less, oral surgery was pretty doable, and I'm sure all of you have done well. All right, so we will start discussing the questions one by one. In case if you feel, this is a live session, in case if you feel that some options that I've written here were not the ones that were present in the exam, you can always tell me. We can together see. The process of the compilation of the paper is still going on. We will have another session once we have all set of 240 questions ready with us, with the best possible language, with the language that was completely present in the exam. So this is just a preliminary session. We will keep having sessions once we get more questions, because our aim is to get a very authentic recall. All right, we want a very authentic recall so that it is beneficial to all of us. So now let's start by looking at the first question. Question 1 says, identify the given instrument. Identify the given instrument. So there's an instrument which is given. I would like to zoom this out for you. There's this instrument that is given. It has 2 hook-like structures. If you see, it has 2 hook-like structures with a rounded wire that is engaging both the hooks. Okay, now just let me give you a little background. In previously, when we did not have electric saws, so this instrument is basically used for osteotomy. All right, for cutting the bone. Now suppose if I have this mandible and I want to do a segmental resection. Okay, if I have a mandible and I want to do a segmental resection, what we can use is this Gigli saw. So you take that barbed wire, you start, like how a carpenter uses the saw, you start osteotomizing the mandible like this, in this motion. So those 2 handles, you hold those 2 handles and you start using this to osteotomize. Okay, Now this is an instrument which used to be used previously before the invention of an electric saw. Okay, nowadays what we use is an electric saw. In some centers where electric saw still is not available, this Gigli saw is still being used. In places where electric saw is still not available, this Gigli saw is still being used. Alright, so this is used for your osteotomy. So the given options were mallet, Gigli saw, nasal rasp and bone gouge. Alright, so your Gigli saw is the correct answer. This is the correct answer. Alright, this is the correct answer. So its function is osteotomy. Its function is osteotomy. Now, next question is, what is the maximum safe dose of adrenaline that can be given to an angina pectoris patient? Very straightforward, simple question. I have, during my classes, I have asked you to put this point in a box that this is one of the expected questions. This question is usually asked during your BDS also. So, angina pectoris is nothing but your CVS compromised situation. CVS compromised situation. If you see my notes, clearly there I have mentioned that the maximum safe dose of adrenaline that can be given to a CVS compromised patient is 0.04 mg. 0.04 mg. The very straightforward one-liner question that I say, this is that. So in the question, if you have anything that is related to CVS, angina pectoris, or say for that matter, if you have a patient who has underwent some treatment for myocardial infarction, or a patient has undergone a coronary artery bypass graft, any situation which tells you that the CVS is compromised, your maximum safe dose of adrenaline is 0.04 mg. This is a one-liner question. Very simple, straightforward. Alright, so the answer here is 0.04 mg. Alright. Okay. Now, the next question. This was a clinical based question. So it says, following surgery for TMJ ankylosis with CCG graft. That is your costochondral graft. CCG graft is costochondral graft. Okay. A pediatric patient returns for checkup after 8 years. It is observed that the chin deviated towards the normal side during mouth opening. What would be the likely cause? Now, how will we come to the answer? Keywords in the questions, which I always say, you have to pick costochondral graft. Costochondral graft is the keyword. Patient returns for checkup after 8 years. Observe that chin deviates towards the normal side. Okay. Now, let's look at our options one by one. The first option says recurrence of ankylosis. It says recurrence of ankylosis. Now, if the patient is going to have recurrence of ankylosis, there will be deviation towards the operated side or the same side. All right, there will be deviation towards the same side or the operated side, and there would be also some difficulty or restriction in mouth opening if it is recurrence of ankylosis. Okay, all right, so these two things are not mentioned in our option, so we rule out this, are not mentioned in your question, sorry, so we rule out this option of recurrence of ankylosis. Now option B, overgrowth of graft. It says overgrowth of graft. Now if you remember, students, in my class I have told you one disadvantage of costochondral graft, that is graft overgrowth. That is graft overgrowth. Okay, now what will happen? Suppose if you have operated on the right side. Okay, if you have operated on the right side, you have put a costochondral graft and the patient is a pediatric patient. All right, the patient still has to achieve the growth spurts, the pubertal, prepubertal growth spurts. All right, now as the child is going, once you have operated, say you have operated the patient at the age of 5 or 6 years, after certain age, depending on if the patient is a male or a female, the patient will have prepubertal growth spurts. Now what happens, that there is growth at the mandible. There's growth at the mandible. Now similarly, what is at the mandibular condyle, sorry. Now what is happening, you have removed the mandibular condyle, so, and you have done a growth center transplantation. If you remember, in my class I have told you that costochondral grafting is a form of growth center transplantation. Why? Because the cartilaginous material present there will cause growth. All right, will cause growth. Now what has happened is, as the child is growing, what has happened, the graft has overgrown. It has overgrown. So what will happen, it will push the mandible towards the normal side or the unoperated side. It will push the mandible towards the normal side or the unoperated side or the uninvolved side because of graft overgrowth. If you clearly remember, in my class I've told you that one of the disadvantages of costochondral graft is overgrowth, is graft overgrowth. So what will happen if you have operated on the right side, if this graft has grown in an uncontrolled fashion, this will push the mandible towards the opposite normal side or the uninvolved side or the unoperated side. All right, so this becomes your answer. Now facial nerve palsy. Facial nerve palsy has different kind of features which are completely unrelated here, Same for MPDS. All right, same for MPDS, that is myofascial pain dysfunction syndrome. Similarly, myofascial pain dysfunction syndrome, there will be tenderness of the muscles and all of that. So MPDS is also ruled out. Facial nerve palsy, there will be, inability to blow the air and all of those features of facial nerve palsy. Again, a completely unrelated option to the history mentioned in the question. So your graft overgrowth or overgrowing graft is the correct answer over here. All right, okay. So now coming to the next question, which statement about TMJ arthrocentesis is incorrect? The first option is landmark used is scanthotragal line, also known as Holman-Helsing line. It reduces, option B is reduces joint pain and inflammation. C, it pushes the disc away from the fossa and reduces inflammation. D, 300 ml RL is injected in superior joint space. Now let's look at our options one by one. Landmark used is canthotragal line. Yes, this is correct, and the other name is also known as Holman-Helsing line. This is correct. Okay, it reduces joint pain and inflammation. Yes, as I have told you in the class, it is basically done to reduce joint pain and inflammation, arthrocentesis. So it is one of the correct options. Now C, it pushes disc away from the fossa and reduces inflammation. See, it reduces inflammation, this part is correct, but it pushes disc away from the fossa, this is not correct. Please remember, in arthrocentesis, we are just doing a joint wash or a joint lavage. In no ways it is compromising the anatomy or distorting or changing or altering the anatomy of the joint space. Alright, it is not pushing the disc, it is not doing anything to the disc, you are just giving a lavage in the superior joint space or the superior joint cavity. Okay, so it no ways, this is absolutely wrong statement that it pushes the disc away from the fossa. No, it does not push the disc away from the fossa. It just washes the superior joint space, takes out all the chemical mediators of inflammation, and you can also introduce medications in the superior joint space through arthrocentesis. 300 ml is injected in the superior joint space. Yes, this has also been asked to me many times on the WhatsApp group and on our club, on our Facebook club. What is the ideal amount of fluid or Ringer's lactate that can be used? It is 300 ml. So option A, B and D are correct, and option C is the incorrect one. So it becomes the answer. Option C is the answer. Okay, TMJ, arthrocentesis. Now let's move on to our next question. So it says, where is the area of biopsy typically taken from? Where is the area of the biopsy typically taken from? It says edge of the ulcer, necrotic area, center of the ulcer, margin of the ulcer. Now there would be, you don't take an biopsy from the necrotic area, you will not take it from the center of the ulcer. Please remember, whenever you take a biopsy, you have to take some normal tissue and some pathological tissue. Alright, you have to take normal tissue and some pathological tissue. So the best area from where you can take a biopsy is the junction of the normal tissue and the pathological tissue. Okay, now the confusion here is edge of the ulcer or margin of the ulcer. Edge of the ulcer or margin of the ulcer. The correct answer over here is edge of the ulcer. I will tell you why. Now, if you remember, when we read the edges of the ulcer, rolled out, punched out, undermined, so that is a very, very characteristic area of the ulcer. Okay, that is a very, very characteristic area of the ulcer, which is also very typical in some cases. So it is, we take the biopsy from the edge of the ulcer. We take the biopsy from the edge of the ulcer, and while doing so, we are not only taking the ulcerative tissue, we also take our normal tissue. So the biopsy that we take is junction of normal tissue and pathological tissue. Junction of normal tissue and pathological tissue. All right. Okay. Question 6, toxicity of LA causes. So in my predictor series also, I told all of you when we were doing the predictor series just a few days before the exam, please to revise the levels of CNS and CVS toxicity. And like I told you, please revise. We had a question in the exam on toxicity of LA. We had a question in the exam on toxicity of LA. Now, if you remember the chart that I've given you, various levels, in that I have told you that first the patient becomes talkative, there is slurring of speech, then there will be convulsions, and then there will be CNS collapse, which is nothing but depression. That is post convulsion depression. First there will be convulsion, and then there will be depression. I had mentioned this in my predictor series also, that wherever toxicity of LA is given, please revise those levels and try to remember that. So I was happy to see this question in the exam that I just told you people 2-3 days back, and this same very question happened to come in your exam. Okay, so it is post convulsion depression. Post convulsion depression is the answer. And I had also told this to you in predictor series. I had asked you to revise this in the predictor series. Okay, post convulsion depression. Okay, is that fine? Now identify the fracture shown in the image below. Again, this very question I have in my class also when I was teaching trauma. After that also I've shown you visuals. I have not only shown you the line diagrams, I have also shown you radiographs of Leaford fractures. And in our DVT session also we had revised the Leaford lines and Leaford fracture. So here, like you can see, this is the fracture line is starting in the frontonasal region, going out laterally from the midline, going out laterally into the medial wall of orbit, going inferiorly. It involves the infraorbital rim, may or may not involve the infraorbital foramen, and then it travels further down inferiorly and posteriorly, and it causes the fracture of the pterygoid plates. So this is very, very typical of Leaford 2 fracture line. Now only over here only I will draw Leaford 1 and Leaford 3 also for you to understand and differentiate. So I'm drawing Leaford 1 with green. So Leaford 1 fracture line will begin at the pyriform aperture, travel posteriorly below the zygomaticomaxillary buttress. It will go behind and cause fracture of the pterygoid plates. Now let's draw a Leaford 3 fracture line. It will start in the frontal nasal region. It will go inside your orbits into your medial wall, then lateral wall, and it will involve the frontozygomatic suture and also the zygomatic arches. This is Leaford 3. Leaford 3 fracture line, and the one that I have drawn with green is Leaford 1, and one with red is Leaford 2. Again, very, very straightforward question. It was a line diagram, it was not even a radiograph, and I have repeatedly shown this. I have put questions also in the tests regarding this same. So very simple image based question. Now there was a question regarding Pedersen's difficulty index. Again, if you remember, this was an image based question. I will just draw the diagram here right now. This was an image based question. I will just draw the diagram here right now. Okay, uh, so if you remember, in my predictor series there was uh, one question verbally where I had mentioned, where we had done a few questions in the predictor series, in which I had mentioned a mesioangular tooth having such and such position, having class this, having class this and this, and position this and this. How would you calculate, or what would be the Pedersen's difficulty index? Okay, now let's draw the diagram that we had in our exam. Okay, so it was something like this. Okay, it was something like this. Now if you look at it according to our Winter's classification, it was mesioangular, hence awarded a score of 1. Okay, now according to Pell and Gregory classification, we have two components. Okay, we have two components. One is the relation between the Ramus relation. All right, we have the Ramus relation, which is class 1, 2 or 3. I will quickly just tell you the Pell and Gregory classification. Okay, Pell and Gregory classification. Class 1. Class 1. Listen and look at the diagram carefully. Okay. Now, how do we define the ramus relation? From the distal surface of the second molar to the anterior border of ramus. Okay, if this is width A and the mesodistal dimension of the tooth is width B, so there is sufficient space. There is sufficient space. Okay, there is sufficient space for the tooth to erupt. Now, what is class 2? Class 2 is there is insufficient space. So that means the distance between the distal surface of the second molar and anterior border of ramus is not sufficient to accommodate the mesodistal width of the tooth. Okay, so here A is less than B. A is less than B, so there is insufficient space. Okay, now what is class 3? The tooth lies in the ramus. Okay. The tooth is in ramus. Okay, this is class 3. Now let's come to position. The second component is according to the occlusal relation, the relationship of the impacted molar to the occlusal surface of the second molar. All right. So this was your ramus relation. Now we will discuss the occlusal relation. The occlusal relation. Now this comes as position. This is classified as position A, B or C. Now what is position A? The highest point of the impacted molar is at the occlusal level, is at the occlusal plane, or it is above. All right, this is your position C. So yeah, the highest point of the impacted molar is either above or at the occlusal level of the second molar. This is position A. Position B. What is position B? I'm drawing this here. Position B is when the occlusal surface or the highest point of the impacted molar is below the occlusal level but above the cervical line. But above the cervical line of what? The second molar. This is position B. And finally, position C. When the highest occlusal point of the impacted molar is below the cervical line, of the second molar. So this signifies a deep impaction. And now how do we score? So like I told you, we all know mesioangular is 1. For class A, again, the score is of 1. For class 2, it is 2. For class 3, it is 3. And for position A, it is 1. For position B, it is 2. And position C, it is 3. Now, let's come back here. If you see, this is mesioangular is 1. And if you draw a line, sorry, first we'll see the class. Okay, first we'll see the class. From the distal surface of the second molar to the ramus of mandible. From the distal surface of the third molar to the ramus of the mandible, there is insufficient space. Okay, there is insufficient space. So this becomes class 2. This becomes class 2, which is given a scoring of 2. Which is given a scoring of 2. Okay. Now, if we look at the position. If we look at the position, the highest point of the occlusal point of the impacted molar is below the occlusal level of the second molar, but above the cervical line. So this becomes position B. Okay, again this is given a score of 2. Now if you add up, it becomes 5. Okay, so there were the 5 wasn't there in the options, so the best option that you can choose is 6, which is the answer. Also, again, since we the exact OPG that was given in the exam, we cannot have that exact OPG with us, so it might be possible that it was a position C in the exam, so that's why accordingly the examiners gave, or it was a class 3 in the exam, that was the OPG that was present, so accordingly we do not know. The exact OPG is difficult to replicate over here, but this is how the question should be attempted. In case one that you're calculating is not present, you try to look at the closest option that is possible. I'm sure it is not definitely 4, because it was a difficult kind of an impaction that was given in the exam. All right, it was definitely class 2 position B, or it was class 3 position B, or class 2 position C, whatever. The mesioangular part no doubt remains. So according to this, it was the best answer that I can think is the correct answer is option B, that is 6. But again, I was very happy to see this in the exam, because again this was a prediction done in my predictor series. This was done in my predictor series. This I had specifically asked you, all of you, to revise. Please revise the Pedersen's difficulty index scoring and index before going to your exams, and we had a question in the exam. Okay, now there's another question. A 20-year-old patient suffers from fracture of mandible as a result of road traffic accident. What is the best treatment option? Now, the options given were a bit confusing, I understand, but when there are such questions, please always stick to your basics. Do not get confused, always stick to your basics. There were 2 or 3 things which I have repeatedly told in my class and in my discussions. Now let's see our options first, then I'll come to the basic points, and then we'll come to the answer. 1 mini plate at external oblique ridge, 2 mini plates, one at superior and one at inferior border, 1 recon plate at the inferior border, and 1 recon plate in between the superior and inferior border. Now there are 2 things. One, whenever there is a fracture fixation, we always look at our Champy's principles. Okay, our Champy's principles. Second, there are 2 things given in this question, 1 mini plate and 1 recon plate. Now you have to look at the mini plate, are the Champy's mini plates, which is are functionally stable and which is most commonly used monocortical ones. Okay, recon plates. What is the indication for recon plates? I've always told you, either a atrophic mandible, or a comminuted fracture, or I told you a malunion or a non-union case where there is persisting mobility after many months of trauma. Okay, and now first thing, what did I tell you? First point is Champy's lines of osteosynthesis. Now, if we look at Champy's lines of osteosynthesis, in my notes, I have made it very, very clear. There is only one plate at the angle, and that too at the external oblique ridge. Okay, or one plate at the superior border, or one plate at the superior border. Okay, now our one mini plate at external oblique ridge, yes, this is our consideration. Two mini plates, one at superior and inferior border, no. According to Champy's lines of osteosynthesis, this is incorrect. At angle, there is only one plate that is placed. Okay, now option C says one recon plate at inferior border. This is partly correct. Why partly correct? If you put one recon plate at the inferior border of the angle, it's a robust plate, so the upper border will splay and open up. So for that, there either you have to put an additional plate, or you have to keep the patient immobilized, or you have to do something else to reduce the splay at the upper border. Okay, so to reduce the splay at the upper border, you have to do something additional along with one recon plate. So one recon plate at inferior border is going to cause splaying at the upper border, so the fracture will open up at the upper border. Again, this is half correct, not completely correct. Now there is one recon plate in between the superior and inferior border. Again, no, what I told you, you can use a recon plate at the inferior border with something adjuvant to take care of this splaying at the upper border. Okay, now one recon plate in between the upper and lower border is wrong. So the best answer here would be one mini plate at the external oblique ridge. Alright, this is the correct answer. Alright, fine. Now again, this question here, I was very, very happy to see this question, because again, if you clearly remember, in my predictor series, I had revised marginal resection and segmental resection with my diagrams, the same diagrams that I've taught in class also. This was also a predictor series question. This was also reinforced in the predictor series. I had asked you to revise. I had drawn the diagrams also in the session. So, and I had also specifically told you, please don't get confused between marginal resection and segmental resection. Okay, I had again very, very specifically told you that please don't get confused. Now, what do you understand by marginal resection? Marginal resection, your marginal resection is nothing but I'm again going to draw the diagrams for marginal and segmental. I'll do it with a different colored pen. Okay. Now let's see what is the result. Okay, here the lower border continuity has been disrupted. Okay, so this becomes your segmental. Here lower border continuity is maintained. There is a margin of bone that is remaining behind, and we leave around 1 centimeter of margin to prevent fracture. To prevent fracture, we leave 1 centimeter of bone behind to prevent fracture. So continuity is maintained. Continuity of the inferior border is maintained. Now let's see our options quickly. So the option A is resection without continuity defect, resection without discontinuity, resection, this is a typing mistake here, resection with continuity defect, resection without discontinuity, resection with normal bony margins, and corticotomy. So resection without discontinuity, that means the continuity is being maintained. This is the answer. This is the answer. Again, had explained it in my notes, and I had also in my predictor series a couple of days before the exam I had reinforced this. So those were the questions that we had from oral and maxillofacial surgery. If there are any more questions that you would like to ask me, I am available on the WhatsApp group. You can ask me there, and I'm sure all of you have done well. Okay, and we also have NICET approaching, so please keep studying, all of you, and we hope to see you all doing very well in all your examinations. Thank you and good luck.